Okay, so thank you very much for joining today. We're joined by, during this Uveal Melanoma Awareness Week, we're joined by some of the team of Brendan Kennedy, Dr. Kaylee Slater, apologies, and Dr. Hushvini. And we're also joined by Melody Buckley, who is a partner of a uveal melanoma patient, and we're going to hear all aspects of uveal melanoma research and the impact of it on a patient today and their families. And it's wonderful. The research we're going to hear is about treatment development for both uveal melanoma and metastatic uveal melanoma. And so I'm just going to show you the Melody has pre-recorded a wonderful presentation on her experience and that of her husband, and going to show that now, followed by Hushvini, or Kaylee, and then Hushvini, and then we'll have a questions and answers session. So if everybody keeps their mic and their video off for the moment, and you can turn them on afterwards for the questions and answer session. So Melody, we'll kick off with you.
I live in Limerick with my husband, Noel. In 2017, Noel was diagnosed with a rare cancer, uveal melanoma. I am talking to you today as the wife of a uveal melanoma patient. Since Noel is not here, I thought I would show you a picture of him with this little owl named Tig. On the day he was diagnosed, he planted these beautiful bluebells, which are still growing in our backyard. In 2016, Noel was having symptoms of flashes in his right eye. He waited a while, and then in early 2017, he visited the GP, who referred him to an ophthalmologist. The ophthalmologist, Dr. Jung Kim, dilated his eyes and diagnosed a tumor in his right eye. Now, this was quite a shock. Noel came out of the doctor's office and just said to me he had a tumor in his eye and that it was eye cancer. And I had never heard of this. Neither of us had ever heard of it. Dr. Jung Kim made a very quick referral for an appointment at the Royal Victoria Eye and Ear in about 3 days. And in about mid-May 2017, he was diagnosed with uveal melanoma by Mr. Noel Horgan, the consultant ophthalmologist at the Royal Victoria. In those 3 days, I went into research overdrive. I really needed to know information before our first meeting with Mr. Horgan. So of course, the first thing I found out was the statistics about that it was most common in Ireland, and the highest proportion of people with uveal diagnosis and that 50% of the patients it was spread to the liver, and if it's spread to the liver, not only die within a year. With this news, it was not good, but actually it was only not good for the people for whom the cancer spread. For those whom the cancer stayed in the eye, they would live a normal lifespan. I looked online for information in groups and found a listserv. Now, so I joined the Ocumel at listserv.ichorus.org and got loads of information. And interestingly, there was a person from Ireland on that listserv who gave me information about Ireland. The group was called Ocumel Ireland, and it was a Facebook group, which I've listed there. We arrived at Noel's first meeting with Mr. Horgan. I had written down all the questions I wanted to ask, and we were prepared. This is the Ocumel Ireland logo. Okay, so we had our May 2000 appointment at the Royal Victoria Eye and Ear in Dublin. Here it is. So we took the bus to Dublin for the appointment. And we arrived in this massive waiting room at the eye and ear, lots of noise. I was, of course, incredibly nervous, but I'm always nervous. But we were calmed when we met Valerie O'Neill, who was very helpful and calming, the clinical nurse specialist. And when we met Mr. Noel Horgan, who was a consultant ophthalmologist. Noel's official diagnosis was a medium-sized choroidal melanoma. Mr. Horgan told Noel that he was a candidate for what's called plaque brachytherapy, and he would go to St. Luke's in Rathgar for it. And this would be a radioactive disc surgically sewn into the back of the eye, and that it would be removed in about 1 week. Noel might spend about 8 to 10 days in Rathgar. He would also he was offered the option of a biopsy, which he agreed to, because the genetic composition of the tumor could provide better information as to whether the cancer would spread. And I'm going to talk about that more in depth. So there's St. Luke's, and 1 week later, Noel and I took the bus down from Limerick to St. Luke's on the 1st of June, 2017. And I spent many hours that first night in a dark, dingy bed and breakfast on the phone with a number of people from Ocular Melanoma Ireland who were very helpful. I didn't have any family in Ireland. My children were living in other countries, and I felt very much alone. I went back to Limerick 2 days later and commuted the rest of the time. After about 10 days, Noel recovered well from the procedure, and we were driven home by a friend. Noel was wearing an eye patch. As we were leaving the St. Luke's, we received instructions for Noel's aftercare, for administering drops, ointment, doing dressings. This all seemed really complicated as it was explained to us. And I thought about what it would be like for people who don't have someone to take them back and forth to appointments or to do all this necessary eye care. Noel was fortunate that he had no real issues with the healing. Mr. Horgan's prognosis for the eye was that Noel's vision would deteriorate gradually, but as of almost 5 years later, he can still see with it. So treatment is not over after brachytherapy. The fact that Noel was healing from the brachytherapy did not mean that we would stop seeing Mr. Horgan. Noel has to continue seeing Mr. Horgan even now, continued monitoring the eye to ensure the tumor shrinks. At first, he was seen every few months, then 6 months, and now 8 months. In most cases, the tumor does shrink, and actually, this tumor, which is called the primary tumor, is much more likely to shrink or not cause any trouble. The problem is if the tumor spreads through the blood to the liver. The importance of the biopsy. International experts suggest setting up a schedule for an MRI, magnetic resonance imaging of the liver, and a CAT scan of lungs based on biopsy results of genetic mutations. I think over time, scanning should become less frequent, but the thing that, of course, is the most scary is that the likelihood of spread is never zero. Noel was referred to a consultant for monitoring to watch the cancer. And that consultant is the wonderful Derek Power, who talks to us, listens to our concerns, and is approachable. Noel has had MRIs of his liver every 6 months and once a year CAT scan of his lungs. So the amount of monitoring is based on the genetic characteristics of the tumor. And if there are no genetic tests, then on the physical characteristics of the tumor. Actually, just going back, one of the most nerve-wracking experiences we had was waiting for Noel's biopsy results. They took much, much longer to arrive, but when they finally arrived, we were relieved to find that Noel was not in the most dangerous category. So the time that I feel the most nervous, and I think we both feel the most nervous, are after the MRI scan, because we don't know what the results would show. And obviously, if the tumor spreads, we he has a lot to worry about. So my additional thoughts. Uveal melanoma does not have the standard 5-year period where if it doesn't spread, it is cured. But fortunately, the likelihood of it spreading decreases over time. We try to live a normal life. This is very important. Of course, it's difficult. The only time I don't feel my life is normal is when I am waiting for the scan results. It's interesting because how do you explain Noel's condition to people when he appears to be in good health? He seems fine. What do you do when you tell people that he never can, that this condition is always ongoing? So there you have my lived experience with I am grateful that Dr. Kaylee Slater and Dr. Huspanis Nimarthi are passionate about studying and eventually finding a cure. Thanks so much to both of you. I would also like to thank the Breakthrough Cancer Charity for funding and publicizing research. Thank you to the wonderful Frances Drummond from Breakthrough Cancer for inviting me here to talk about my lived experience. And thank you for your attention.
Melody, that was just very, very powerful. That was an amazing synopsis of an incredible experience. As you say, the things that come to me are the fact that we don't know about uveal melanoma, even though Ireland has one of the highest incidence in the world. And the other thing is, as you say, living afterwards, going through the treatment is one thing, but living afterwards and communicating about that and the anxiety around the scans and everything. So that's just really, really useful. Brendan has a question there. Do you, Brendan?
Well, I just put in an emoji to say well done to Melody. But so Melody, thank you again for all your input to us. And although I've heard you speak on this before, every time I hear it again, it puts it all back in context for us. So that was powerful, and it helps us understand from the patient perspective the real day-to-day realities of this. So thank you. That was great.
Firm date for their results. Students are usually given their marks in August, but this could be delayed because of a second sitting of tests in July. JJ Charles reports in an
sorry. I thought that was a question. That was a news report. So so we'll have more questions and time for reflections afterwards. So now I'm going to ask Kaylee to present her work, please. Thank you, Kaylee.
Yeah, just let me share my screen here. Can everybody see that?
Yeah.
Okay, great. Just get the pointer. Perfect. First of all, I just want to say thanks to Melody as well. I completely agree with Brendan. It's really important for us as researchers to hear that side of things, because it's very easy to get caught up in the day-to-day things in the lab, and it's really important to remember what the overall goal here is. So as Frances said, my name's Kaylee and I work in the Ocular Pharmacology and Genetics Research Group here in the Conway Institute in UCD. And some of you might know that May is Melanoma Awareness Month, but that also makes it Ocular Melanoma Awareness Month. And the disease that we work on in the lab, which is uveal melanoma, comes under the umbrella of ocular melanoma. So I'm really glad to be here during Ocular Melanoma Awareness Month to talk a little bit about uveal melanoma, about our uveal melanoma research team here in UCD, and specifically about some of the research that I've done over the last few years, which is on this protein here called cis-LT1. So I'll talk a little bit about some of the work that we've done on that as well. So before we go into the research, I think it's important to just show you the team that we have here working on this. So as I said, we're a part of the Ocular Pharmacology and Genetics Research Group here in UCD. And the lab was established almost 20 years ago now, so in 2003. But we only started working on uveal melanoma in 2017. So the people I've showed here are just a proportion of our lab, but these are the researchers that are solely dedicated to working on uveal melanoma. So as you'll see, when we started in 2017, it was just Brendan and I, and also Yolanda, whose photo I don't have here, but she's the project manager of our EU grants, kind of working on uveal melanoma and trying to figure this all out. And in the last 5 years, we've really been able to expand this and grow the research team to have these dedicated researchers working solely on uveal melanoma. And everyone that you see on the screen here has been in the past or is currently, or in the case of Valentina, will be in the future funded by Breakthrough Cancer Research. So as a lab, we have actually found it quite difficult in the past to get funding for uveal melanoma research, just given the rarity of this cancer. But thankfully, Breakthrough Cancer Research have really recognized the value and the need for funding rare, poor prognosis cancer like this, and like so many of the other cancers that they also support. So we have to say a big thanks to Breakthrough Cancer Research for organizing this today, but in supporting our research in general over the last few years. And I know today that Husni and I are going to give an overview of some of our research projects, but if you would like to hear more about some of the Breakthrough Cancer Research funded uveal melanoma research, you can check out their website. They have a piece on all of our different funded projects there. So now I want to talk to you just a little bit about uveal melanoma, and I'm aware that the audience that we have here might be a bit mixed. So some people who are familiar with uveal melanoma are probably experts on this. You've seen that from Melody's talk, as she said, if you or someone that you know or love becomes affected by uveal melanoma, you become an expert researcher, and I can confirm that Melody is definitely an expert researcher. She has taught me so many things over the last few years that we've worked with her. But as she rightly said, uveal melanoma, which is sometimes referred to as for short, is a rare form of ocular cancer that arises from melanocytes, which are the pigment containing cells within the uveal tract. So that's made up of the choroid, which is a vascular layer at the back of the eye. So this is where Melody's husband, Noel, his uveal melanoma was diagnosed. It can also be found in the ciliary body, which is at the front of the eye and controls lens shape. Or it can also be found in the iris, which is the colored part of the eye that some people are probably a bit more familiar with. And the distinction between uveal melanoma and ocular melanoma is that you can also have melanomas that occur on the eyelid or on the conjunctiva, but they are different to uveal melanoma. So what we work on is exclusively uveal melanoma, so only melanoma that occurs in one of these three places. And on that point, it's just really important to mention also that not only is uveal melanoma distinct to some of those ocular melanomas, but it's also distinct to cutaneous melanoma, which is more commonly known as skin cancer. So more recent advances for the treatment of cutaneous melanoma unfortunately don't translate into uveal melanoma. And again, as both Melody and Francis rightly alluded to, it's really important that we consider that Ireland actually has one of the highest incidence rates of this rare cancer in Europe and possibly even in the world. So I think that just really highlights the need for there to be ongoing research on this rare cancer here in Ireland. Again, as Melody rightly said, unfortunately, in half of all patients, this cancer can spread through the bloodstream. And when that happens, it most commonly goes to the liver. And once this occurs, the prognosis for patients can be quite poor because there are very limited treatment options available for these patients. So as you can imagine, and again, as Melody described so well through her own personal experience, a diagnosis of uveal melanoma and sometimes metastatic uveal melanoma is obviously extremely devastating for patients and their families. So there's still very much an unmet need there and a need for research to discover why and how the cancer metastasizes, and importantly, how we can stop that and treat patients when it does occur. So in terms of some of the risk factors, then, although I've just said that uveal melanoma and cutaneous melanoma or skin cancer are two completely different diseases, you'll notice that many of the risk factors are quite similar. So if you have fair skin, if you have light eyes, or if you don't tan that well in the sun, you're at a higher risk of developing uveal melanoma. And what you might realize is that these risk factors are very characteristic of the native Irish population. So as you can imagine, that might give some indication as to why we have such a high incidence of this cancer here in Ireland. In terms of the symptoms, again, Melody described this so well, but some patients are often asymptomatic, so they have absolutely no symptoms at all. Other patients might have blurred vision, they might see flashes or floaters within their eye, or they might have some pain within their affected eye. So usually what happens is a patient might have some ocular symptoms, they go and see an ophthalmologist, and it's only then that the cancer can be diagnosed. So something that's really important, and I know that Melody and the others in Ocular Melanoma Ireland really try and promote, is to have regular eye exams with dilation. So having your eyes dilated allows for an ophthalmologist to actually see into the eye, look in the back of the eye and see if there's anything suspicious going on there. So this is something that couldn't be, incorporated into your normal checkup routine, is to have regular eye dilations to keep on top of your ocular health as well. In terms of the treatments then, Melody also described these. Some patients, for their primary tumor, will unfortunately have to undergo an enucleation, which involves complete removal of the affected eye. Others, in the case of Melody's husband Noel, will receive radiation therapy. That could be brachytherapy, which is performed here in Ireland in St. Luke's Hospital, where Noel, Melody's husband, went. Or some patients are referred for proton beam therapy, which takes place not in Ireland, but patients have to be referred to the UK for this treatment. Fortunately for some patients, this is the only treatment that they will ever need, and the primary tumor won't spread or progress into a metastatic disease. But unfortunately, as we talked about previously, half of all patients will develop metastatic disease. And once this occurs, the treatments that are available for these patients are quite limited. So some patients might have surgery, they might have standard chemotherapies, some patients are given immunotherapies. This was previously really based on ones that worked in skin cancer, but didn't have very high effectiveness in uveal melanoma. But this year, there's actually been a major development in the treatment of metastatic uveal melanoma, and that is with the approval of tebentafusp, which is also an immune-based therapy, but this is the first therapy to improve overall survival in a metastatic uveal melanoma patient cohort. So on the right of the screen here is an example of how this drug works. And I know this looks very complicated, even for me to look at, it is, but I think it's important for us to understand how this works in terms of considering how we might design future therapies for uveal melanoma. So in the orange here is the drug itself, so that's tebentafusp. And what this drug does is that it binds to the cancerous melanoma cells, but not to your normal healthy cells. And in order to do this, the melanoma cell has to have two tags, if you like, for the tebentafusp to recognize it. So the melanoma cell has to have this GP100 tag, and it also has to have a HLA-A2 tag. And this is really important because this tag is only found in 50% of uveal melanoma patients. So even though this treatment is effective, it's only effective in those 50% of patients that have that tag. Another thing that I just want to highlight down here is that tebentafusp, when it binds, it recruits immune cells to the tumor. So that means that it's harnessing your own immune system to attack the tumor cells. And one of the things that it does to promote this is it releases these inflammatory factors or mediators that are known as cytokines. And this allows for more immune cells to be recruited to the tumor. So I've just listed some of them here, and they're a bit important to remember for some of the research that we conducted, which I'll talk about later on. So where does our research fit into all of this? I said at the beginning of the talk that I have been specifically interested in this protein, which is called cis-LT1. And again, I know this diagram might look a bit overwhelming, but the important thing to note here is that cis-LT1 is like a lock that sits on the outside of your cells, and it can be activated with a key, or it can be inactivated with other keys. And basically, when this protein is active, it can cause things like tumor growth, it can cause survival and spreading of tumors, and we know it has quite a big role to play in inflammation and in other cancers, such as colorectal cancer. So we thought, what if we could block off this lock using a specific drug called Q7? Would we be able to turn the key in the lock and lock this pathway off? And would this be something that could be used and could be beneficial in uveal melanoma? So one of the first things that we did was to look and see, is this protein actually relevant to uveal melanoma? So we know it was relevant in other cancer types, but is it relevant to this cancer? And to do this, we were extremely fortunate to be able to work with 2 different patient cohorts. So these were samples from Spain and from Liverpool, taken from patients who had undergone this enucleation procedure where they had their eye removed for the treatment of their primary tumor. And basically what we were able to do was to stain pieces of these tumor tissues to see how the levels of this protein were inside of primary uveal melanoma tumors. So essentially what we're looking for is how pink the tumors turn when we stain for this particular protein. So you'll see in the very light pink ones, we'd say that this protein is quite lowly expressed. Then we'd have kind of an intermediate pink here where we'd say it's moderately expressed. And then we would have some patients that would stain very dark pink, and we'd say that they have quite high levels of this receptor or protein cis-LT1 within their tumors. And what we were able to show was that having high levels of cis-LT1 is actually associated with poor outcomes for uveal melanoma patients. So again, these graphs can be a bit tricky if you're not used to looking at them, but the important thing to note really are these red lines here, which represent the patients that have high levels of this protein. And what we can see from both our Spanish cohort and our UK cohort was that patients that had high levels of this protein were found to die sooner from metastatic and just die sooner overall. So we were able to show that high levels of this protein are linked to patients dying from metastatic uveal melanoma, and this led us to believe even further that cis-LT1 could be an important target in uveal melanoma. So this brings us back to the original schematic that I had, and at this point we wanted to try and introduce some drugs that would be able to turn the key in this lock and block off cis-LT1 in uveal melanoma. So Q7 is the drug that I'm going to talk about today. And our initial studies focused on looking at what this drug would do in cell lines. So these are cultured cells that are taken from patients either with the primary tumor or with the metastatic tumor, and they're grown in the lab, and you can keep them for years. They just grow as a single layer on plastic dishes like this, and we can do lots of different experiments on them. And one of the things that we saw, which was really nice, is that when we treated both the primary cell lines and the metastatic cell lines from patients, is that Q7 had a really big effect on how many of these cells remained alive. So you'll see here, the survival of these cells was really reduced in both the primary cell line and in the metastatic cell line. And I think you can really appreciate that when you see this picture here. So this would be the untreated cells versus those that we've treated with Q7. So for us, all of these results were obviously really exciting, but they are initial results. So we wanted to bring this forward into more representative models of uveal melanoma. And one thing that we've been really fortunate to be able to do in collaboration with our colleagues in the Royal Victoria Eye and Ear Hospital and Mr. Noel Horgan, who Melody also mentioned, was to collect primary uveal melanoma tissue samples from patients that have undergone an enucleation procedure. And we can culture these tumors, which basically means that we grow them in the lab. But unlike the cell lines that I talked about before, these are not a flat layer of cells. We maintain them as a tumor, and all of the associated immune cells and everything else that would be growing alongside this tumor in the body is maintained. So this is a much better model for us to be able to use. So what we did was we collected the media, which is just the liquid that the tumor has been growing in, and we're able to look and see if any of the any inflammatory factors were released from the tumor, and if these were associated with any anonymized patient clinical characteristics. So again, bear with me because I know this graph isn't the easiest to interpret, but the most important thing is just to understand that these red circles indicate a negative correlation. So what that means is that we saw that when patient tumors had high levels of inflammatory factors secreted into the media, that this negatively correlated with the patient clinical characteristics. And most of these characteristics are ones that we know already are linked to poor prognosis. So for example, we saw that when the tumors released high levels of IL-13, that this negatively correlated with the thickness of the tumor. And we know quite well that the thicker the tumor, the poorer the prognosis for the patient. So that shows that having high levels of these factors secreted is something that's beneficial for patients. We were also able to then use these tumors and treat them with our drug of interest, Q7. As I said, these tumors are a much more representative model than the cell line model, because again, we have all of the immune cells and all of the cells that would be associated with the tumor in the body still intact. And what we saw when we used Q7 was that Q7 was actually able to increase the secretion of lots of these different inflammatory factors. So IL-13, IL-2, and TNF-alpha were all significantly increased when we treated the tumors with Q7. And if you remember back to when I was talking about tebentafusp, this is one of the ways in which tebentafusp recruits immune cells to attack the tumor. So for us, this is a really promising result because it shows that Q7 is also able to promote an immune response within these tumors. Lastly, I want to talk about one other model that we use in the lab, and this is in collaboration with Xenopath, who are a Spanish company based in Barcelona. And as I said, cell line models are great, but unfortunately, sometimes we have to use higher order models, particularly in rare diseases and poor prognosis cancers, as they can give us the most real insights before we would ever put a drug into a patient. So this model involves inserting metastatic uveal melanoma cells into the liver of mice. This is surgically done by an expert in Xenopath. And then we use these mouse models as a way of testing our drugs, in this case, Q7. So this is an example of what you can see. This would be the liver, and this is one of the tumors growing within the mouse liver. And when we treated with Q7, one of the things we saw was that although our Q7 didn't decrease the weight of the tumors at the end of our experiment versus the untreated mice, the weight of the Q7 treated tumors was significantly lower than the mice that had been treated with dacarbazine. And this is a chemotherapeutic agent that is often given to metastatic UM patients. So this would really argue against the use of that chemotherapy, which we already know from clinical trials is not very effective. So tumor weight is just one thing to look at in terms of this experiment endpoint. So another thing that we wanted to see was, could our drug actually affect these liver tumors inside the tumor, and what was happening on the inside of the tumor? So for tumor cells to grow and to spread, they need energy. Like us humans, in order to be active, they need energy. So one thing that we looked at was a marker of this energy to show us how much energy was being produced inside the tumor. And again, what we saw was that when we used our Q7 drug, we were able to significantly decrease the amount of this energy marker within the tumors. So that suggests that Q7 is able to have an effect inside of these tumors, which for us was an amazing result, because the liver is a notoriously difficult organ to treat, and liver tumors are very difficult to treat. So this shows that our drug is active in liver tumors, and that inside at a molecular level, it's able to mediate changes, one of which is affecting the energy inside the tumor cells. So just to summarize some of the work that I've talked about today, what we've been able to show so far is that patients with high levels of this protein, cis-LT1, have a poorer prognosis or a poorer outcome than patients that have lower levels of this protein. We've been able to treat primary uveal melanoma tumors with Q7, which is a drug that locks off cis-LT1, and we see that Q7 increases the secretion of inflammatory factors from these tumors, and we know from treatments like tebentafusp that this is something that is positive for uveal melanoma. We've also shown that Q7 can be effective in a model of metastatic uveal melanoma, and that it can actually mediate molecular changes within the tumors and can have an effect on the energy production of these tumors. So going forward, the things that we're currently focusing on are determining how exactly does Q7 affect this immune cells. So we'd like to have a schematic like what I showed you for tebentafusp, and we're also working to expand this work to include more patient samples, to include metastatic liver biopsies and patient blood samples into this work as well. So I just want to highlight some of our clinical collaboration that we have ongoing through this project. As I said, we only started this in 2017, but fortunately we've been really lucky to be able to collaborate with clinicians all over the country. So we have work ongoing with Mr. Noel Horgan in the Ioneer, with Professor John Crown in Vincent, with Dr. Calvert in Waterford, and we're hoping to extend this to Galway and to Derek Power in Cork, which Melody also mentioned, and we also have some interest in expanding this to Northern Ireland in Belfast. So I think we as researchers really see the need for this research, but so too do the clinicians, and most importantly, the patients, who are always extremely eager to be involved in the research as well. So with that, I would just like to say thanks to all of our funders who make this research possible. Obviously, Breakthrough Cancer Research play a major role in that. We also have lots of fantastic collaborators, both nationally and internationally, that make so much of this research possible. And lastly, I just would like to say thanks to all of the uveal melanoma patients that have been involved in our research to date. Thank you for listening.
Thank you very much, Kaylee. That was just really, really fascinating, actually. And just because it's Uveal Melanoma Awareness Week, thank you for highlighting the risk factors. But is there any way, are there any preventative measures that we could take as a nation?
Yeah, it's a really good question, and unfortunately not really. So unlike cutaneous melanoma, which is very strongly linked to UV exposure, uveal melanoma isn't. There are a small subset of the uveal melanomas, so those in the iris, that may be associated with UV, so you can wear sunglasses. But unfortunately, that doesn't really seem to be protective against the uveal melanomas in the back of the eye.
So just in the iris or
yeah,
whatever. Okay, thank you very much. So we've no other questions at the moment, some lovely comments, but we'll come to them afterwards.
Francis, sorry to interrupt you, but I see there's a hand up.
Oh, apologies, thanks, Brendan. I don't, oh, there, Nellie, yeah. Nellie, would you like to unmute? Nellie, do you have a hand up? Apologies, you're not unmuting there.
Muting. Yes, no, I must have pressed, I'd have no questions really. I must have pressed something by mistake.
Don't worry.
Yeah.
Okay, we'll have time for questions anyway in a minute. And so, Hushvini, would you like to share your screen?
Okay, so hi everyone. I'll just put on my pointer.
And just Hushfidi is coming to us from Singapore today.
Okay, so thanks, Francis. So I'm a postdoctoral researcher in Professor Brendan Canby's lab and part of the OPGG group doing research on So Kaylee has given a very nice introduction to as well as the work she has been doing. So I'm going to talk more on my project. And before I do that, I'd like to thank everyone who has been involved with us in our research. So from OPGG group to our project manager, Yolanda Alvarez, members of the OPGG group, all of our collaborators, the co-facilities within Conway Institute in New City with whom we work closely with, and our enterprise partners or industry-based partners such as from Bioreperia, Pharma Hungary, and ICON, and of course our charity partner Breakthrough Cancer Research. And a special thank you to Dr. Francis as for being my enterprise mentor throughout my postdoc position, and all funding agencies including IRC, Top Meten, Mercury Actions, 3D Neonet, Crystal Cube, and especially to patient advocates from Ocular Ireland and Melody for working closely with us on our project. So today I'm going to briefly talk about our research focusing on uveal melanoma and advanced melanoma and the things, so different types of work we actually do in the lab. And we are keen to raise awareness on this rare disease and also a bit on how we can work together as a team together with the public. So as Kaylee mentioned as well, we have a couple of international collaborators as well as national collaborators. We work with some clinicians in Spain, but we also work with our industry partners in Sweden, as well as in Hungary and in UK as well. And hopefully we can expand our research further as we proceed. So on the research front, in my research, we are particularly interested in histone deacetylases. So this class of proteins or group of proteins are known to be involved in regulating gene expression and transcription. In the context of cancer, these histone deacetylases are known to be involved in promoting cell survival and differentiation, and even helping these tumor cells to actually spread and grow new blood vessels. And studies have shown that if we are able to block these processes with an inhibitor, we may actually slow down the tumor cells from growing or even surviving. In particular, I'm interested in HDAC6 inhibitors. The reason being HDAC6 inhibitors are slightly different compared to the other HDACs in the sense that they primarily act on proteins that are found in the cytosol, meaning when we are targeting this particular protein, we may not be eliciting with a global change or controlling at the epigenetic level in this case. And not only that, HDAC6 inhibitors are currently in clinical trial for various other cancers. So therefore, we were interested to address the question on whether HDAC6 inhibitors can be effective against the survival of and advanced cells. And if so, how does this drug actually works? In particular, we are focusing on the drug ACY-1215 because this is currently in clinical trial, meaning we know that it's safe and it's well tolerated by patients. And in the event that it does seem to have a beneficial effect against cancer, then we are one step closer to trying to repurpose the drug in terms of as a therapeutic or treatment option in clinical trials in the context of MUM. So I started off in the lab to look at how ACY-1215 has an effect in our cells. So as Kelly mentioned, we grow cells in the lab that are derived from the primary tumor, which is in the eye, or tumors that has a spread. So this would be in the liver. So these particular cells are called the OMM 2.5. So what we did was we grew the cells in the lab in a flask, and then after that we treated them with a different concentration or increasing concentration of the drug ACY-1215 for 96 hours, after which we removed the drug and allowed the cells to grow. And what you can see over here is that with the treatment, we have a significant loss in the number of cells present, or there's barely any that is actually surviving our life. When we compare it to our controls, where you can see a lot of cells happily growing, and also with, as Kelly pointed out, to dacarbazine, which is a clinical control, and that's routinely being given to patients. So as we saw that we do have a promising effect observed in vitro, we wanted to know whether this can be addressed or observed in vivo as well. And primarily our goal is to find therapies or treatment options for advanced melanoma. So all of my future data comes from the OMM 2.5 cells, which are from cells that have tumor cells derived from the metastatic tumor to the liver. So in this case, we wanted to test in an in vivo model, and Kelly showed our mice xenograft models that were used. But in my case, I was looking into creating a xenograft or tumor models in a zebrafish larvae. But because we did not have any experience creating these kind of models, I went to Sweden and worked with our industry partner BioViperia, which was supported by the 3D Neonet Consortium, to learn how to create these models and then to screen our drug candidates of interest. So in this case, what we did was we took the OMM 2.5 cells and we labeled them with a dye that can fluorescence. So in this case, it will be red in color. And then this group of cells were injected into 2 days old larvae, and then they were treated for 3 days with our drug of interest at our desired concentration. And after 3 days, we analyzed to see whether the tumor has grown or regressed or what's happening basically. And we were pleasantly surprised or happy to find that there was almost a 60% reduction in the tumor fluorescence on average. So this was really exciting for us, because we were able to see that this drug has a beneficial anti-cancer effect, not only in cells grown in the lab, but also if we are transplanting them into a fish model. So now the question was, how does this drug actually work? So as we saw that the cells were being killed or they were not surviving when we were treating with the drug ACY-1215, we used an assay called flow cytometry analysis to look at what happens to the cell cycling process or to the cell death mechanisms. And what we saw that after treating the cells for 24 hours with our drug, the majority of cells were actually stopped in the S phase. So this means the cells are no longer able to move along the cell division process that's required to multiply the cells. And by 96 hours of treatment, more than 80% of cells were found to be actually going to be dying, or like in late stages of apoptosis or cell death, or they were actually dead. So you can see in this micrograph where all the cells are, almost most of the cells are floating, so instead of being attached. So this means the cells are actually dying. So now we have a piece of a story where treating these OMM cells with ACY-1215 is telling the cells to go and die instead of being able to survive and grow and multiply. So we wanted to know what is the signal that's actually being given to these cells to tell them to die instead of grow and survive. So therefore, we decided to look at the proteome of the cells. So this is to look at all the different protein that's present within the cells, and then to try to understand how the protein profile is actually altered or changed when we are treating them with the drug. And in this case, with our analysis, we found a transcription factor, in this case it's called MITF, and to be significantly downregulated when we are treating them with the drug ACY-1215. The reason this factor was quite striking for us is because in cutaneous melanoma or in skin cancer, this factor has been implicated to be involved in the tumorigenesis processes. So that means we were curious now to know whether MITF plays a critical role in the UM or MUM cells as well. So therefore, we decided to take a pharmacological approach by inhibiting or blocking the MITF signaling pathway. So we use this drug called ML329, and we performed similar assays as described previously, where we looked at how this drug affects the survival capability of the cells in the lab in vitro and also in vivo in zebrafish model. And what we saw was that by treating the cells with ML329, a majority of the cells were unable to survive in vitro, and also there was almost 55% regression in the primary xenograft fluorescence in vivo. So this drug was also seen to be quite effective and able to work on its own to prevent the MUM cells from surviving. And so this is one part of our work that we have done, and we are now trying to understand in great detail, because all this work were done in cells in the lab. We want to know how effective these drugs are actually in patient samples. So there's more research that actually needs to be done on these two drugs before they can actually go on to clinical trials. So the second part of another project that we are involved in is to try to look and understand about the drug ergolide. So this is a compound that's like isolated from flowers from the species Inula britannica. And traditionally, it's used as a medicine for treating inflammatory diseases and stroke. And in the context of cancer, they have shown that it's capable of it's an inhibitor of the NF-kappa B pathway. And this drug actually triggers the cells to undergo apoptosis or undergo cell death. So why this is interesting for us is because in liver metastatic tumors, basically from the tumors that have metastasized in UM patients, they found that the NF-kappa B2 expression level was quite high. So we wanted to know whether if we block this pathway, will we able to prevent cells or tumors from growing? So we used similar experiments and assays as before, whereby we treated different concentration of the drug ergolide on our OMM 2.5 cells. And again, we saw at different concentration that these cells were unable to survive in vitro. And when we tested in vivo using our zebrafish model, we saw that there was almost 50% reduction in the fluorescence that we could see, indicating that this drug is indeed quite active as well, not only in vitro, but in vivo. So at the moment, we are now trying to understand how this drug ergolide works, and by looking again at the proteome profile, and we are looking at other inflammatory markers, because Kaylee also mentioned about the inflammatory system pathway or being quite important in UM. So we are trying to see how we can link between the NF-kappa B signaling pathway and ergolide. So another part of this work is looking into extracellular vesicles. So the reason is extracellular vesicles and the cargo are known to play important roles and in cancer and progression. And it has been used to, studies have shown that you can use them to identify novel prognostic markers or novel therapeutic targets. And also we can manipulate them for drug delivery. But we were really new to this topic and area of research. Therefore, we decided, and I went to visit Pharma Hungary, a company, our industry partner in Hungary, under the Crystal Cube Consortium, to learn from experts on how we can isolate these vesicles from our cells, and also to understand what it means if the vesicles are altered or modified when we are treating them with an anti-cancer drug. As this was a different cell line, so we are now have established a protocol to try to properly isolate the EVs, and these have now been drug treated with ergolide, and we are now in the process of analyzing the data to look at how or if any changes have occurred in the vesicles when we have treated them with ergolide, because this will give us a lot of information in terms of if we are able to identify novel putative markers and targets for novel treatment strategies. So this is a summary of the research work that's currently ongoing from my side. And so overall, we have 3 novel candidates that have shown potential to be anti-MUM effects for in vitro as well as in vivo. But again, as I mentioned, this is still in early stages of the research. We still need to do extensive studies to understand how these compounds are actually working, and also to test whether these drugs are effective in patient samples as well, and whether they would be suitable as a global treatment option or a small cohort of patients. So now I will change our focus a bit and talk about our Uveal Melanoma Awareness activities that we have been ongoing in our lab since last year. So as Kaylee mentioned, this month of May is the Melanoma Awareness Month, and Ocular Melanoma Awareness Month is also in part of May. And we want to raise awareness and understanding of UM because it's a rare disease. Another aspect was to try to normalize the wearing of eye patches, because most patients, as Melody mentioned as well, after treatment or post-treatment, they are required to wear an eye patch to protect their eyes. But as these activities, when we were planning, so mostly I'm going to talk about activities we have done last year and also some that are ongoing at the moment. But because we were in the midst of a pandemic, we had to decide to use social media to try to engage with our audience as well. So with our awareness activities, we have our clinical partners, industry partners, patient advocacy groups, and of course, charity partners involved in trying to promote and work together to increase the awareness on UM. So I'm going to share a video or a simple animation video that we have created together with all the partners I have mentioned before, and some of you may have actually already seen this video. So our goal was to create an animation video that's easily understandable. It's free to access because we have posted this video on YouTube, and normally when someone receives a diagnosis, as Melody mentioned, it's quite a shock, and it can be a lot of medical terms and jargon. So we wanted to keep a simple video that everyone can take it to process the information that's given. So I'm hoping it actually can play.
Uveal melanoma is the most common cancer observed in the adult eye, with diagnosis most prevalent in ages between 50 and 70 years. In Europe, there is an increasing incidence rate geographically from south to north. Some uveal melanoma patients experience no eye symptoms. Others self-identify a problem in one eye, and some cases are uncovered during routine visits to the optician. Symptoms can include blurred vision, flashes, floaters, visual field loss, and distorted vision, which may cause pain or headaches. Dilation of the eye by an eye specialist can enable visualization and diagnosis of uveal melanoma. Uveal melanoma should not be confused with cutaneous melanoma, also referred to as skin cancer, which has different disease course, root causes, and treatment options. The precise cause of uveal melanoma is unknown. However, risk factors include lighter eye color, fairer skin, and the inability to tan. Ultraviolet radiation has been linked to the development of a small subset of uveal melanomas originating in the iris. Uveal melanoma commonly develops from the abnormal growth of melanocytes, melanin-containing cells lining the inside of the eye. Uveal melanoma develops in the uveal tract, the middle layer of the eye. The uveal tract is composed of the iris, the coloured part of the eye that controls pupil size, the ciliary body, an extension of the iris that controls lens shape, and the choroid, a blood vessel-rich layer that nourishes the inner eye. Choroidal melanoma is the most common type of uveal melanoma, followed by melanoma of the ciliary body and iris. Uveal melanoma is classified into 4 groups according to changes present in chromosomes and regions of DNA within, known as genes. Each group has different levels of risk of the disease spreading to other organs. Defects in chromosomes 1, 3, 6, and 8, and changes or mutations in the DNA sequence of genes such as GNAQ, GNA11, and BAP1 are linked to uveal melanoma. Changes in these genes can lead to the growth and development of uveal melanoma, or can cause uveal melanoma to spread outside of the eye. For example, loss of one copy of chromosome 3 is associated with increased risk of metastatic disease. Uveal melanoma can spread to other organs of the body, becoming a metastatic disease in approximately 50% of patients. Uveal melanoma most frequently spreads to the liver, but it can also spread to the skin, lung, soft tissue, and bone. Once the tumour has metastasized, the survival prognosis of patients is relatively poor. The most common treatments for primary uveal melanoma include radiation therapy, laser therapy, and sometimes surgical removal of the eye. Radiation and laser therapy aim to shrink or kill the cancer using intense energy or focused light. Usually, treatments of tumours confined to the eye are successful. A biopsy of the tumour can help determine the class and course of disease. If the cancer spreads to the liver, the tumour may be removed surgically, or patients may receive liver-directed treatments such as percutaneous hepatic perfusion. Despite increased understanding of the causes of uveal melanoma, there remains a crucial need for more effective treatments. The inclusion of uveal melanoma patient tumour samples from the eye and liver into research studies is invaluable. These samples help to create additional models of the disease, which help to broaden our understanding and to develop patient-specific therapies for the treatment of primary and metastatic uveal melanoma. As uveal melanoma is a rare disease, it is vital that clinicians, patients, and patient advocates, scientists, pharmaceutical companies, and governments collaborate nationally and internationally to improve diagnosis, enhance treatment options, and increase accessibility of clinical trials to patients.
So this is the video we actually created together with ICON, a clinician, Breakthrough Cancer Research, as well as our patient advocates. If anyone would like to have a video, we are happy to share the link as well for the video. So prior to the release of our animation video, we ran a month-long campaign during May last year, and we wanted to engage with the audience as well. Therefore, we decided to run a Twitter poll to also gauge the knowledge that people have on UM. So we asked simple questions like, which organ does this cancer originate, or which country has the highest prevalence for UM? We asked a total of 5 questions, after which we gave 24 hours for the vote to be cast, and then we released the answers with supporting evidence. We were actually quite happy with the outcome because they were quite interactive, not only with us, but also writing comments and engaging with each other in terms of the questions and answers that was being posed. And we also, to end of our campaign, we did a design your own eye patch competition. Our rule was very simple. It was to be as creative as possible. And so that's an example of the submissions that we have received. A member from Ocular Ireland judged the competition to shortlist the submissions, and then we used Twitter and Instagram poll to select the final winners. Because we had a lot of submissions from different age groups, we decided we need to split the categories into the children's category as well as the adult category, and then we selected the winners. So the full-length video of these eye patch designs that was submitted to us is also available on YouTube, where you can go and view them. So our selected winners was this was the selection for the adult category, and this was the eye patch design selected for the kids category. In addition, we are quite actively involved in raising funds with Breakthrough Cancer Research as well, and we have created a UM information piece that's available in the Breakthrough Cancer Research website as well. And last but not least, we are currently actively working to establish a Uveal Melanoma PPI panel. So this panel is to have patients and public to be involved in our research so that you can give your opinion and perspective to shape our research instead of us just telling you the work we are doing, but to work together with us as a team so that we can improve the end results, because all of us have the same goal, which is to improve the survival and quality of life for patients with UM. So if anyone is interested, or if anyone you know might be interested in being part of this panel, please feel free to contact us in um.ppi@ucd.ie. So the link is given over here. Or even if you would like to just know more about UM, we are happy to answer any questions. With that, thank you for your attention.
Thank you so much, Hushvini. Both you and Kaylee's crammed so much amazing information into those, and sorry, Melody as well, huge information. I mean, my take home is that we now, after your research, have 3 new target drugs, some of which are already, you know, in used as therapies. So that means the pathway to treatment is potentially shorter, which is wonderful. And also, I just want to ask you, what's the importance of using the different models that you're using? If you can answer this succinctly for the audience, and also the importance of the patient samples. So there's 2 different questions.
Okay, so I'll try to answer it simply. But when we are working in the lab and when we are using cell culture, so my research, for example, would only be focusing on one particular cell type. But as you may know, as in the video when we mentioned, there are different genetic mutations that may take place as well. And the current treatment that has been approved, tebentafusp, it only, as Kaylee mentioned, works on a cohort of 50% of the patients who had a specific marker type. So this means that the other 50% of patients may not have a treatment option or therapy, right? So that's why we want to look at multiple different targets and try to understand to see if we are required to have multiple, drugs for subset of patients, with different genetic mutations, or can one drug be perfect or suitable for all? So this moves us towards the concept of personalized medicine or targeted medicine and therapy as well. Yeah, so you don't want to only look at one particular drug and it may not end up being effective when it's actually in the clinical trial, because in our research we are controlling a lot of factors actually when we are in the lab, and this may not be the case when you're actually doing it with the patients. Yeah, so we have to account for all these variabilities as well.
Yeah, that's wonderful. And as you said, going towards the personalized medicine approach. And Kaylee, just the difference, how important is it to have patient samples? Or
yeah, so I mean, I think that just really elevates our research to a whole other level. As Hushvini said, working with cell lines in the lab is one thing, but they all come from one patient. They've been there for years and years and years, and over time they don't really represent a tumor as well as the patient samples do. So we can get those samples fresh. They've, come from a patient who's consented for research. So all of the immune cells and blood vessels and things that interact with the tumor when it's actually either in the eye or in the liver are still intact. And I mean, we know from some of the therapies that are available for that things like immune cells, things like blood vessels, they are so important. And if we don't have a tumor or a model that can represent that, well, then we're missing out being able to find something that can work there. So really, it brings our research to a whole other level and makes it so much more relevant to what's actually happening in the clinic and in the disease in the patient.
Yeah, so you have the whole environment, not just the one cell with maybe just one genetic etiology. Wonderful, thank you. And we have a question from Liana Drummond, no relation, I don't think. Thank you for a very informative session. Is there any indication of the reasons for a high incidence of uveal melanoma in Ireland? And is the high incidence also present in the Irish diaspora across the world?
Yeah, that's a great question. As I said, I think it's that the risk factors that we know are associated with just seem to be characteristics of a lot of Irish people. Things like, light eye color, fair skin. Like I know myself, I have all of those things, don't tan well. So those things are obviously characteristic of Irish populations, but also other populations. So we know in Northern Europe in general, uveal melanoma is more prevalent, but in terms of whether or not it's high across the diaspora, I actually don't know. It's a really good question, but even the statistics that we have within Ireland are very new. So the Ocular Oncology Service in Ireland was only set up by Mr. Horgan in 2010. So we're kind of waiting for more recent and updated figures on that, but it's a really interesting question, Liana, and would be an interesting study for someone to do. I would presume yes, based on the characteristics of Irish populations in general, but I actually don't know myself.
There's no known genetic etiology. No.
Can I just say
Yes,
something?
Melody?
There are various registries in America that are registering ocular melanoma patients. They are also looking at certain places that they think may be places where there's a large number of people. I forget what the word is for that.
I think clusters of people.
Clusters, yeah. What we noticed in our group is it seems like there were a number of people from Donegal. I don't know if that's a cluster, but I just want to say something else. Noel is what you'd call a Black Irish. She has dark hair and very dark eyes and ruddy skin. They do, I'm on various face groups for ocular melanoma all over the world, and there is a proportion of people that don't fit the Irish stereotype, even if they are Irish. I don't know why so many people in America are Irish Americans have ocular melanoma also, but I think there may be something beyond just the fair complexion and the fair skin, because there are a lot of people with dark eyes like my husband who have it. I mean, this is anecdotal, I'm not a scientist, but there are registries that they are trying to find some information, general information.
Yeah, thank you. Well, I'm sure after that, we're all much more aware of uveal melanoma, some of the causes and some of the risk factors, and also some of the breakthroughs with regard to the treatments that are coming online, the possibility of personalized medicine down the line. And Melody, I can only thank you very, very much for sharing your and Noel's experience, and continued good health to Noel. And if there's no further questions, yeah, just everyone saying, look, really, thank you, brilliant presentations, and I would concur wholeheartedly. And just thank you also, Hushvini, for reminding us again of the brilliant resources that that your team have made available, and we'll all make them available through our website again and through social media again today. So if there's no further questions, I just wish to thank you all very, very much, and let's. Basically, it's looking good, and thank you for all your work. Thank you, and thank you for your awareness and raising, Melody. Thank you all.
Thanks so much.
Thank you.
Bye, everyone.
Bye.